here, and I would like to welcome you all and to talk a little bit about the wines that we are going to serve for you. Okay, the first sparkling was the House of Arras. Have you ever heard of House of Arras? It's probably the best sparkling wine in Australia. It's from Tasmania. Ed Carr is the winemaker. It's been open for 30 years, and in 2021, it was awarded the best wine in the champagne and sparkling competition, international competition in London. So it's quite a very highly regarded sparkling wine. I hope you're all enjoying it. It's the Arras Brut Elite. It's a blend of Chardonnay, Pinot Noir, and Pinot Meunier. Very fresh. The house style is extended yeast contact that gives a lot of complexity, brioche kind of characters. And that was the sparkling. We already served the white. For the white, we're going for something that is very close to home for me. It's from the north of Italy, from the Valpolicella region. The Valpolicella region is just near Verona. You know Verona, the city of Romeo and Juliet. Now, this wine is quite unique. I don't know if you had a taste. It's quite unique because they use only red grapes to make this wine. So how do they make a white out of red grapes? You might know, but the color is actually on the skin of the grapes, not on the juice. So basically, they press the grapes quickly and they separate the juice from the skin without the extraction of the color. The result is a very aromatic. I hope you all had a taste, and if you're missing out, just let me know and I'll give you some more. Very aromatic, white flowers aromas, white peach, and some lovely texture there that will go very well with the entrees, the canapes that we're serving for you. I hope you enjoy it. Thank you very much, and I'll talk more about the other wines later. Thank you.
Hello everyone. My name's Hannah Barclay. I'm the Director of Australian Specialist Hub. So I just wanted to take a moment to thank you all for coming. We're going into our 5th year of operation at the moment with over 1,800 specialists that currently work with us. So it's been a bit of a wild ride. And something that was really, really important to me when I started the company was that the examinees were treated, well, in my mind, properly. Someone, they come to their assessment and feel like they're being heard. Everyone has a chance to tell their story and feels like they've had a fair and thorough assessment. So we've sort of been following that mantra and we've just seen enormous growth because of that. I've had a quick look at the slides that we've got for our specialists today, and I think you're in for a real treat. So on that note, I'll hand over to one of our pain specialists, Professor Molloy. Thank you.
So, okay, how does that all work? It comes up in here?
Yeah.
Thanks.
So when you want to go back,
Just go. Yeah, okay.
just that there.
Do you want to fire it up now then? Sorry,
It's already on.
Oh, it's around there, is it? Oh. Oh, okay. Good.
Is it working?
Nearly.
Nearly.
Yeah.
Let's try. Is it up?
Nope, not this one. No. Yeah, one button. Yeah. You can find it. Okay, then go across. Yeah.
So I'll give you that one. So you can either talk into this one here
Yeah,
or
thanks.
that one as well.
Okay. Yeah. Sorry.
Would you like to use this one or this one?
I'll just use that one. It might be easier. Shall I? Oh no, maybe I'll use that one then. Yeah, sure. Yeah. Because I can walk around with it. Yeah. Okay. Thank you. You all hear me? Okay. Chronic pain is a massive thing, of course, and I realised the other day, I think I'm the oldest pain specialist practising in New South Wales. That's because I've been around so long. I started here in 1992 at North Shore, and I'm still there working. So I work as a pain specialist and anaesthetist, and I do medico-legal. And I think that gives me the whole spectrum from pre-surgical, acute pain, into chronic pain. So I've got that whole link, and I'm still practicing and still enjoying it, thankfully. But I must admit, I thought we would have got further in 30 years, and I don't think we have. Because if really, the one metric that upsets me greatly is if you look at the workers' comp tail of chronically, the chronically disabled people, we haven't shifted it. In fact, it's got worse. So I think that it's actually sort of, the number of people is getting worse, and return to work hasn't been improved in terms of the different time points. And that's a bit of a mystery why that happens in a way, but I don't think it is, because I think, in a sense, I think Australia's got kind of a bit of an acute pain problem dealing with it. It's very narcotic based, and I'll explain to you what I mean about that. If we look here, there is a belief still that, I think your symptoms are in your head. So there's in the system, the workers' comp system, there's a disbelief that people are in pain. Because it's not something you can see, is it? It's a report. It's always a report. And it's based on what you see. So I could have hobbled in here today and said I'm in pain, and you go, oh, poor guy, I wonder what happened to him. But I wouldn't be in pain. Similarly, someone could sit there, and by the odds, there's about 15 people here with chronic pain. Headaches, probably endometriosis, probably someone's got a knee pain, a hip pain. There's someone here today with chronic pain. Just by chance, just by the nature of things. But you're working, so there's people who work with pain and people who don't. And why haven't we impacted the chronic pain problem? One example in my acute pain practice is with knee replacements. There's a way that was described in Australia to get people who've had a full knee replacement, that's about as painful as you can get them up the same day and home the same day. And that's what's used in America, Copenhagen, the UK, but not Australia. We want 4 days in hospital. We want to go to rehab. And that's all lovely, but it's not actually affordable, and it causes, if you don't do a sort of a get up quickly type of thing and use everything you can, you're risking a 30 to 50% increase in morbidity just by not getting them up. But that's tolerated in New South Wales Health still, but they're talking about doing it 25 years later. And similarly in workers' comp, there are so many, I feel, blocks in the system that just lead to chronicity. It perpetuates chronicity, and I'm just saying to a couple of our attendees today that the benefits of good work and this metric of I think within workers' comp, it seems to be very important, return to work rates, which it is, but I think people are pushed back to work too early when they're not ready, and I think the blind use of this, you must get back to work in some form, is harmful at this point. But it's what is still used, and I'm trying to do something about that, but it's very difficult to have a voice in these systems. So the discrete injuries are easy. There's loads of them. We all have them. They get better, and we all get on with it. Everyone's had an injury, I'm sure, here at some stage, and it's got better, and you've been fine. It's predictable, but with chronic pain, something diverges, and it's often not sudden. It can take time. You're just not right. The pain has continued. You start to see specialists. You're losing sleep. You're starting to take drugs. Your work's not going well. Everyone at home starts getting sick of you, and they don't want to talk to you because you're complaining all the time. So there's this chronic sort of divergence off a normal trajectory, which is not visible often. And I liken it to when you go to the beach which we all love to do, I hope, you go between the flags. And the people, the chronic pain patients, the person who has the discrete injury is between the flags. They could go out and they come straight back in. But the chronic pain people are the ones who are going in the rip. And often, if you're not watching, it's silent, isn't it? You don't hear someone in the rip. And if someone drowns in the ocean, that is completely silent. So often you don't know this is happening until it's too late, until these things are quite embedded and the early treatment options haven't been explored. So there's the ones who, so 20% of the clients, of the claimants, produce 80 to 90% of the costs. And they're the ones where there's a mismatch between. They're the ones with, I believe, and it's hard to get this data because it's within the system somewhere. They're the ones with PTSD, functional neurological disorder, depression, anxiety, all sorts of psychosocial factors, plus pathology. Okay, how's that so far? Is there any other question? So early on, as you know, you get tissue injury, inflammation. It's all proportional in the first phase, and everything works. You get back to work, and happy days. Now, 30 years ago, we thought we had the answer. Who's watched Dope Sick? No one. Well, that's your homework tonight here at this table. You've got to watch Dope Sick because it shows you what happened in the 90s in pain clinics, because the Sacklers engineered this approach with narcotics with no evidence, but it was supported by all the pain societies, and then it was supposed to be so easy. Give them narcotics, they're all going to be better, happy days, and we've solved the problem of chronic pain. But in fact, what we saw were people were just dying. And Dope Sick is an incredibly accurate depiction of what actually happened, because I think it's just so true, you know, and it's what I lived through in 1992 onwards, and we're still dealing with that now, you know. So I do recommend it as an educational thing for anyone working with chronic pain patients and also narcotics. So when they transition, we get to central sensitization. So we start getting a memory of pain in the system. People get worried, they lose their confidence, they get anxious, depressed. Fear of pain is understandable. Nobody in this room wants to be in severe pain, I'm sure. I didn't like it when I had a really bad toothache. I didn't know what to do. And it was pretty severe, I can tell you. But nothing like what I'm sure the patients go through. And their functioning isn't in keeping with what you can see on the X-ray. So X-ray looks fine. There's nothing wrong with the discs. Everything looks fine, but they're lying in bed taking painkillers. And so they start getting in the rip at the beach. So they're not between the flags, they've gone outside, and they're being pulled away onto the rocks, into the danger zone. And I do believe that that's quite a good analogy for patients, anybody dealing with claimants. If you look at them and say, okay, are you between the flags? No, you're not. So what do we have to do to get you back between the flags? Does that resonate with anyone? Yeah, okay. So often what I think people, often you feel like some of the pain programs are a little bit like, have you tried meditation and just challenging your thoughts? When in fact, they're describing their pain as though the whole body's on fire, or there's electricity running through it. It seems like it's like trying to fan them with a hat. It's just not, the treatment's not proportional to what they're describing. But there is difficulty with treatments. So one of the things is at the moment is that in pain clinics we have interdisciplinary, so you can go to a pain specialist, he just acts alone, he does all his stuff, he rarely mentions psychosocial factors, he's busy trying to find the pain point, doing blocks and stuff. There's multidisciplinary, which is the kind of the gold standard. But the problem is that might mean that you're seeing the physio in the high street, the psychologist in another high street, and the pain specialist. So they're not talking, they're not working together. And often the psychologist, for example, doesn't have expertise in chronic pain, so no training. They're just general psychologists. And interdisciplinary is actually the gold standard, where everybody works together in a team and we discuss cases. And that is typically mostly in urban academic centres like Royal North Shore. I'm not saying North Shore's the best, I do work there, but I'm not saying it is. But that's where you have those resources typically, and research. Now, sorry, how much time have I got? Because I just want to ask questions, because I'm kind of... 10 more minutes? Okay, all right. So, and then we get into this long-term phase where it all becomes kind of chaotic, where there's researchers say there's change in the nervous system, there's pain behaviours, there's a lot of drugs being taken, there's a lot of inactivity, they're retreating from society, there's a lot of things going on. And healing has taken place, and the psychologists we work with say that what you see is largely independent of what happened originally with the injury. So the injury happened, healing's taken place, and we come fast track forward, and what you're seeing is independent largely of what, because healing's taken place. There's another new set of contingencies that have developed. And we were talking about trying to get them back to work, and then it becomes, at this point, looking at marginal functional gains. You can only get, the idea that somebody at a couple of years who hasn't worked is going to get back to their pre-injury work is just not. And it's often the question, will they get back to their pre-injury job? And you think, like, it's no, but I know you have to ask that, but it's more about getting minor increases in function. And the question is, if we just wound back to 2 weeks or 4 weeks, could we make the big difference then and just stop this long-term disability? I think you can, but the system isn't ready for it at the moment. So often the medico-legal conflict is the structural findings, and there's a little bit of cherry picking sometimes. The orthopaedic surgeons often don't have a modern interpretation of chronic pains. They say, oh, this person hasn't got anything wrong with them, there's nothing on scans, and they should go back to work. And this person lying in the bed yelping on narcotics and cannabis. So that's not going to work, despite what the surgeons say. And there's a number of them working who repeatedly say that, which is very unhelpful, because the system takes notice of that, and then someone gets denied benefits, and a year, 6 months to a year of denied support and benefits is a long time to then come back and say, oh, sorry, we got it wrong, we'll give you them now and we'll play catch up. It's a very damaging thing. It's still better just to treat the person, get them to MMI, and then finish the case. I don't think there's any benefit in that, denied liability because someone without domain expertise said that everything was fine. It doesn't, and to be honest, I think malingering is very rare. It's just not, you just don't see it, really. They are out there, people are out there, but it's a pretty hard system to negotiate as a malingerer, I think. Like, you've got to be pretty, pretty focused. The variable symptoms, mistaken for inconsistency, or, physio says that they looked like they were fine when they weren't with them, or they saw them in the high street and they looked fine, or they were dancing at a party but said they couldn't work, things like that. You often have to adjudicate in that. And some patients say they go to IMEs 5 times a week. They say they're always going for an assessment. They say it's a full-time job. And there's a lot of evidence showing that that is very traumatic, because they have to tell their story again and again and again 5 times. And then they look for differences in the story and inconsistencies. But if you've got, say, PTSD and you have to keep telling that story, that's very distressing. as you can imagine. Like it shouldn't be like that. Okay. So all the testings come back normal, but they say, but it's testing normal, but you're still suffering. It's just, that, why is that? Everything, your scans are all normal. It doesn't make sense, but it does make sense because the scans don't show pain. They just show gross structural abnormalities. And we know that young people in pain often don't have abnormalities on scans different to people without pain. So we don't recognize complexity. Use of narcotics sensitizes people to pain. The care pathways are fragmented. We don't work as a team. And we may not recognize these psychosocial drivers such as PTSD and fear avoidance, depression, anxiety. So what works? They all work a bit. And it's somehow you have to try and match the person to the treatment, which I think what we have to do in this area is start to measure, have visibility of patient-reported outcome measures. Now, this is something that Sarah did 2022, but they haven't mandated it. So I think we have to do regular check-ins and find out how that patient's doing, or else it's invisible. If someone's depressed and anxious, you can't, it's not written on their forehead. You have to measure it somehow. And if you do a patient-reported outcome measure, it's surprising how accurate it is. That's their voice. They will tell you what's happening to them. So all of these work, but it's matching it. Oh, sorry, one second. And my latest gripe is the variability in pain programs. It's reasonable to think that they're all the same, but they're not. Generally, the outcomes with pain programs are mild to modest. They are not big. And even the ADAPT program at North Shore is very mild to modest. But there's a lot of programs out there that have never submitted outcomes. They just say they're like ADAPT and they never have to. We pay for those, and I think it's inappropriate care. If you don't match the treatment to the patient, it's inappropriate. It shouldn't be allowed. And we need to measure those outcomes. Because if you look at the final box, it says harms. Even the ADAPT program, which is supposed to be the gold standard, some patients have report what they call relative decline of 38%. So just jumping back on that, we've got to remember, is Louise here? Sorry, Louise? No, not yet? Where's Louise, sorry? Oh, okay. Oh, okay. Oh, wait. So I just want to be aware. Psychiatrists and psychologists have never traditionally recognized that they might do harm. They've always couched their approach as neutral or positive. But in pain programs, you can get significant harms because you're trying to do things very quickly with them. And we need to measure that. So don't think that it's all neutral or positive. With all this, it can be very negative for a range of reasons, complicated reasons. And that's really important, I think, to remember. So that's another big variability. There's now the Boost program that run the ward. There's the Navigator program. There's so many. And if you look into them, you can't find out what they do. It's a mystery. So medico-legal experts do a range of things. Often it's just whatever we're requested to do. And key take-home message: pain changes and evolves over time. There's a mismatch of treatments, which is often not anyone's fault, but it can be just laziness, and that drives disability. I think we need to move to early intervention, just like you would with somebody at the beach who's between the flags, goes in the rip, and the surf lifesavers go out and get them. And in New South Wales Health, one of the biggest changes in safety in New South Wales Health was between the flags. And all they did was say, if you're measuring someone's pulse and it drops, you turn that into actionable data. You don't just say, oh, it just dropped, and leave it. You actually do something about it. And that drops, the number of heart attacks dropped by 42% just by taking notice of the data. So that was called between the flags. So don't just measure it, do something about it. Okay, I think that's probably it. Have I got? Yeah. Okay. Any questions? There's a lot to cover there. Hello. Yeah. We look at. Okay. Yeah. So it's when does, I think the question is, when does pain become chronic, and how do you put that in a report to determine capacity? So one thing we have to remember is that anybody with chronic pain is characterized by nothing has worked. So whatever you've done, it hasn't worked. Nothing's worked. So for some people, that might be 2 weeks. They should have got better at 2 weeks, but generally it's 3 months. It seemed to be the point. At that point, you've got someone with reporting pain and disability, but pain is, as I said, a report. It's just sort of, it's this, that, and that, and you have to look into the components of that to determine capacity and treatment. So if the pain is 7 out of 10, what are the components of that 7? Because that's just a number. That doesn't help you treat them. Are they depressed, anxious, fearful, worried? Have they got PTSD? Have they got, nerve injury or fractured bone or whatever? So you have to work out what that pain is due to. Yeah. Well, so we're just wondering, if someone is disabled with persisting pain, how do you then make a decision whether they can work again? Well, the point, to my mind, within any chronic pain presentation, the pain is generally not going to settle. So they've got a chronic pain condition the rest of their lives, unless there is something that you can surgically fix, or mostly they have chronic pain. But within that, there's modifiable factors, such as depression, anxiety, fear, catastrophizing, self-efficacy, range of things, and you have to target those and see if you can improve them to improve function. If you can't, and there's no other treatment, so if they've done the ADAPT program and the team there say that's as good as they'll be, then in 9 months they're MMI. I would have thought, that's it. Yeah, can you improve them from that baseline? Yeah. Hello. Yeah.
How do you know which pain program is more effective? What do we look out for in terms of pain programs, and what's the ideal duration?
Okay. The best guide to that is I think there are statewide guidelines within New South Wales Health called the ACI, which program, and I can share those with you. But you can look them up, and they came out quite recently, and they describe a range of measures you take and you match them to the program. That's all you can do. So for some people who are depressed, severely depressed, anxious, self-efficacy is maybe below 20, catastrophizing is high, they need 120, 100 hours plus of treatment. But if those aren't so, they say a lot less. So that's all you can do. So that's an example of matching treatment. So make sure that person with all those doesn't go into a lightweight program that's 3 hours a week for 5 weeks, because it's mismatched treatment. Yeah. Yeah.
What's the best way to sort of risk categorise a return to work capacity, and what capacity should you be looking at, considering in the same way that capacity is probably harmful for most patients, no capacity is probably equally harmful, considering most treatments are aimed at grade of exposure, whether it's interventional trying to gain access, psychologicals, grade of exposure, and some capacity physical therapies, same idea. So we should be able to sort of calculate in some way whether 4 hours a week or 4 hours a month or 10 hours a month or whatever would be a adequate level to provide grade of exposure to get better outcomes. How do we do that earlier, and then how do we do that somewhat accurately and safely?
I think what you do is, again, you measure patient-reported outcome measures as a measure of how their voice and how they're thinking and responding. And then you consider whether they need to be optimised according to that model, if they need a pain program or not. So if there isn't a medical treatment, and current best practice is if there isn't, then if there's abnormalities, if their PSEC is below 40, they should do a pain program. And then that program, the outcomes from that should be used to inform return to work. So that should set the ground for a pain management approach that would be implemented in the workplace. That's all you can do. So you kind of get a baseline, and then they build up within their tolerance and their capacity. That's all. Yeah, that's it. That's about it. I don't think, yeah.
There's no rocket science answer to it.
But it is an important gradation that they get treatment, and that's if they respond to whatever level. If they don't respond, that's what we base it on. And I think that then, at the end of that program, at say 6 months or 9 months, if there isn't, like if the psychiatrist says there's no treatment for their treatment-resistant depression or their drug, whatever, PTSD, their MMI. That's it. And I think it's unfortunately, it's quite a straightforward progression, because they've had the treatment, you paid for it early, and there's no point them roaming around the system just doing more IMEs, and, you know, it's better to exit the system and get what the system might give them. Yeah. Okay. So, yeah, so thank you so much. I think there's, the one thing that did come up was CRPS as an entity. That's not, it's an uncommon disorder, but common in pain clinics. And generally there's an 18-month window for treatments before it becomes chronic. So I think that's what some of these, I think most of them, in fact, what we need to do is have visibility, recognise those who are doing badly, and institute treatment early, even if it doesn't work. I'm not saying it's going to work in everybody, as I'm saying, but just apply it, but learn from it. So we need to collect the data and know if that program over there is getting better outcomes than that one there. And that will be a big data thing. That's not for any of us. But we've got to learn from the system. We can't just have unwarranted variation in, oh, I do this, but I do that. Yeah. Okay. Thank you.
Thank you, Dr. Molloy. And now we have, I think, ready for Mauro for the next wine. I think you've all got your glasses ready.
Thank you. Questa qua.